now we have another interesting, most awaited session. I would say all of us this today logged in only to hear, particularly for this. And my personal wish and desire was also to talk to Dr. Leon sir in a open platform on sharing some of his ideas in future and how it evolved in his life. Before we go to that, we have a special lecture by Dr. Martin B. Leon, a futuristic look at the valvular heart disease, clinical needs and visionary concepts. He has been always visionary and thought about how to do good things to the patients in less invasive way, and how this progresses in future. Let us hear to this from Dr. Martin B. Leon. Over to you, sir.
Well, thank you again. That was truly an inspiring address by Dr. Reddy. She is incredibly articulate, and I think she summarized some of our strongest feelings. These have been challenging times. So for friendships to be maintained, we have to use creative activities to be able to keep ourselves connected and to share ideas. This will be a lecture that's derived from something that an address that I'll be giving at the ESC in the next coming months, that hopefully puts in perspective some of the things we're not just doing but are dreaming about doing, hopefully in the near-term future. These are disclosures that are important for you to be aware of. I want to begin by pointing out something that Dr. Reddy mentioned, which is growth and access to care in valvular heart disease has risen to the level of being a crisis. If we look at as a result of global aging, the incidence of moderate or severe aortic stenosis and mitral regurgitation will exceed 150 million persons by the year 2040. So this access to care crisis results from both underdiagnosis and undertreatment. So an example is currently, even in the United States, thought of as being a progressive country with complete access to technology and care, less than 1 in 4 patients with severe symptomatic aortic stenosis that has been diagnosed receives aortic valve replacement, either surgery or TAVR, within 1 year of diagnosis. And we know that the mortality of untreated severe symptomatic aortic stenosis can be between 25% and 50% in the first year. So clearly this is a crisis. And the question is, how do we confront this? But one of the things that's being doing, which I find interesting, is to apply some of the new informatics and some of the new big data concepts that surround artificial intelligence and machine learning to be able to screen populations for a high likelihood of valvular heart disease. There was an initial manuscript last year from South Korea, most recently this year, European Heart Journal from the Mayo Clinic, shown on this slide, indicating that with a 12-lead standard ECG, that they could achieve sensitivity, specificity, and accuracy of the diagnosis of significant aortic stenosis at a very high level. Now, we've been doing this work at Columbia as well with our cardiovascular informatics team, and just submitted a manuscript to Jack and presented our early data at the TVT meeting last week using an artificial intelligence model to detect not just aortic stenosis, but aortic regurgitation and mitral regurgitation from standard 12-lead ECGs. And as you can see on the right of the model performance, the area under the ROC curve was quite acceptable for AS 0.65, for AR 0.79, for MR 0.84, and overall for any of the valvular lesions 0.83. We are now validating this in a prospective echo-based study. So these interesting techniques that would allow us to improve access to patients by improved screening, I think could be important in the future. Another way to use artificial intelligence and machine learning is by better analysis of the imaging materials that we use to diagnose valvular heart disease. This is work done by Partho Sengupta, who is a brilliant AI cardiologist who's published some extraordinary work looking at machine learning concepts to integrate echo measurements to augment the classification of disease severity in patients with AS so that we can prioritize and understand who are the patients that need to be treated most urgently. So I believe in the future with this population growth and with access to care becoming so much of an issue that we need to be creative, with not just device technology, but with things like artificial intelligence and machine learning. Now, I want to talk about the various valvular lesions. They are at very different stages of development. When we look at TAVR as a transcatheter technique, as of the current quarter, there have been about 1 million cases that have been done throughout the world. If you look at transcatheter mitral procedures, that number is closer to a little over 100,000 cases. And if you look at transcatheter tricuspid procedures, it's only about 10,000 cases. So when we try to describe different therapies, you need to keep into context the different developmental stages of these three valvular lesions with regard to transcatheter therapies. Beginning with aortic valve therapy, I always have to introduce my colleague, Alain Crebier, who did the first proof of concept case April 16th, 2002, in a man in his 50s with bicuspid aortic valve disease, cardiogenic shock, no arterial access from the aorta, profound LV dysfunction with a large LV thrombus. And this was done without transesophageal echocardiography or general anesthesia, and now 15 minutes post-TAVR. When we talked to Alain about what the next steps would be, we really thought this procedure would only be for the sickest patients who did not have surgery as an option. We could not have predicted, as shown here in the most recent version of the TVT registry, the explosive growth in TAVR. And you can see in that shaded yellow line how the growth now exceeds all forms of surgical aortic valve replacement in the United States since the middle part of 2018, with a compound annual growth rate of about 20%. This is extraordinary and beyond what our imagination has been. I don't want to go into the reasons why there's been so much growth, but I will say in the beginning, we never thought that we could treat patients who are in this so-called low-risk category. And I think part of the reason why we've seen such growth is that we brought a great deal of evidence. And the evidence is in the form of well-conducted randomized trials, as shown here in 2 studies that were done with 2 versions of TAVR and presented at the ACC just 2 years ago. So we can now describe the clinical care pathway for a low-risk AS patient with a same-day admission, 3/4 of the patients without general anesthesia, a femoral artery puncture without chest wall incision or cardiopulmonary bypass, in a procedure that takes less than an hour, with most patients returning to the floor and not an ICU, and most patients being discharged in 1 to 2 days, 96% of which were discharged to home or self-care. This is remarkable compared to what we had experienced 15 years ago. These patients have rare procedural complications. In the low risk category, the 30-day and 1-year mortalities were extremely low, very low stroke rates, less pain, bleeding, acute kidney injury, and procedural arrhythmias, and improved early recovery. This is the power of TAVR. Right now in the United States, about 1/3 of patients being treated already fall into this low risk category. But there are still many evidence gaps when we talk about aortic valve therapies and TAVR, and I'm simply going to list them on this slide. Probably highest is bioprosthetic valve durability, the importance of valve leaflet thickening and valve thrombosis, the use of cerebral protection devices, things like TAV and TAV procedures and the safety of failed TAVR surgical explants, the issue of coronary access, especially in younger patients, confusion about echo-derived gradients and their concordance or discordance with clinical events and invasive hemodynamics, the issues of patient prosthesis mismatch in small annulus patients, how we deal with post-TAVR conduction disturbances, and a new concern, which is new left bundle branch block, the optimal antithrombotic pharmacology, concomitant cardiovascular diseases, including coronary and multivalve and AF, the whole issue of bicuspid aortic valve disease treatment, and then things like asymptomatic severe AS and what I would call at-risk moderate AS subgroups, the new treatment of aortic regurgitation, and how we manage the lifelong journey of a patient with aortic stenosis in terms of therapy sequencing. We're not going to address these issues because we don't have time, but you should be aware that even with all of the success, we still are challenged and we still have many issues that need to be addressed. What I want to talk about is something that is interesting to me, which is what I would call upstream AS treatment, which is treatment that we never would have considered had we not had TAVR, and that we never would have considered if we adhere to the traditional paradigm of only treating the most severe symptomatic patients. So when I describe upstream treatment, I'm talking about asymptomatic severe aortic stenosis, at-risk moderate aortic stenosis, aortic valve remodeling procedures, not replacement, and even medical therapies, which many people think is a radical shift. There are 2 trials that are ongoing and more to start. The early TAVR trial is approaching conclusion of enrollment. Over 800 patients have been enrolled of a cohort of 900. This is the largest randomized trial looking at early TAVR versus active surveillance, which is watching the patients in a randomized trial, carefully organized with very rigorous endpoints, will tell us if asymptomatic severe aortic stenosis should be treated earlier. Similarly, we have a study called TAVR Unload, which are patients with moderate aortic stenosis who have clinical heart failure and reduced ejection fraction. We've demonstrated they have a high event rate. Maybe they should be treated sooner. This study is about half completed and will bridge into another trial called the Progress trial, which is a much larger study in moderate aortic stenosis, looking at a variety of at-risk features that would allow us to potentially treat upstream, earlier, moderate AS patients before they reach the point of irretrievable disease severity and irreversibility of certain changes. This is a new device. This is called a Leaflex device, but it's been in development for 10 years. It's Israeli technology. I've worked with this group for a long time, and it's a scoring device that actually scores the leaflets in a very specific way that improves leaflet flexibility. They looked at over 1,000 surgically excised human valves and developed this technology and are now in clinical trials that are in Europe, an early feasibility study beginning in the United States in a few months. And as shown here, this is a device that potentially could improve or remodel the leaflets in a way that you could either delay or not require aortic valve replacement in some patients. So we are exploring this as an upstream treatment that might allow us to modify the natural history of valvular aortic stenosis so that fewer patients need valve replacement at a younger age. Again, upstream treatment. And finally, and this is care of some of the courtesy of some of the work of Brian Lindman, the idea of medical therapy is returning, and we're developing some very creative tools to look at medical therapy with 2 approaches: to really modify the progression of calcific aortic valve disease directed towards the leaflets and the annulus, but also in patients that have chronic afterload, there are myocardial changes, and those changes can be mitigated by a variety of pharmacologic interventions, as shown on the panel on the right. So we're excited about the opportunity of being able to actually consider medical therapy and aortic stenosis in the future as well. And then lastly, this issue of bioprosthesis durability. We spent a great deal of time in the most recent VARC document to define what bioprosthetic durability is in very specific terms with sequential imaging and clinical presentation. And it's a complex process, but now we at least have uniform definitions. There is no question that we will see failed TAVR valves, balloon expandable, self-expanding. There's also no question that in the future, that new bioprosthetic valve platforms and non-bioprosthetic polymer-based platforms will be introduced and tested with improved durability profiles. This is an example of one of them called the Intrepid Duravr transcatheter valve that is beginning human clinical testing in the next 6 months, that has acellular detoxified leaflets that reduce calcification without glutaraldehyde, some very interesting features that we think might have an impact on durability. So what is the future vision of aortic valve therapies? Well, on the right, you see a pie diagram, which indicates at least my feeling that clearly TAVR will be the dominant AVR technology in the future and the default therapy for most AS anatomic scenarios. The evidence gaps that I mentioned must be addressed and resolved, especially in younger patients. The conversation will shift to bioprosthetic valve durability and preferred therapy sequencing. When do we do surgery? When do we do TAVR, first or second? This concept of upstream earlier use of TAVR in at-risk AS will become a common theme, including the development of valve remodeling and medical therapies, and innovation will focus on machine learning for screening and device phenotyping and novel, more durable valve leaflet technologies. Now let's shift our attention to mitral valve disease. Many unrealized expectations on transcatheter mitral therapies, largely due to the complex anatomy shown on the left, over 60 devices that have been taken into early stage evaluation by 2021. So this is a complex disease with many overlapping solutions. Right now, transcatheter edge-to-edge repair, or TEER, is the so-called current winner. It is being used preferentially in most patients, both for primary and secondary MR, now based upon fairly good evidence for secondary MR on the COAPT trial that was shown on the right, which only is a portion of the secondary MR patients, but at least gives us good evidence to indicate improved symptoms, reduced mortality. So this is certainly a technique that needs to be integrated into therapy. I believe that also, though, replacement therapies are now rapidly evolving. This is just a partial slide of the many TMVR devices that are being developed. Encircled in red are those that have now achieved transseptal reality in that they can be delivered from a transfemoral transseptal approach as opposed to a transapical approach. Some of the advantages of replacement is that it's somewhat agnostic to the anatomy, and many more patient subcategories can be candidates. The high surgical risk patients that would get open MVR or as an alternative to surgical MVR. There are some MAC patients, rheumatics, endocarditis, MR recurrence after surgical repair, or those that are unsuitable for edge-to-edge repair. So I think there is a possibility of treating more patients with TMVR. Among the systems we are most familiar with, this is the Intrepid valve. It's a very interesting a conformable outer stent with an atrial brim with anchors that don't necessarily have to capture the leaflets or need rotational alignment. There's a circular inner stent that houses a tri-leaflet valve. It has certain features that are attractive. It's among the many of the new TMVR systems. I show this slide just to give you an idea as to what it takes to develop a program like this. We began in 2014 with pilot studies, and we've already had the beginnings of a randomized trial that's had to be reorganized into a single-arm study. We're doing work now in the MAC subset. We're evolving this into a transfemoral transseptal device that is in an early feasibility study that will be subjected to and incorporated in the single arm and future randomized trials. It's a very difficult process. Over 300 patients have been treated with this device and with as much as 5-year follow-up. And this is simply the trial design of the current pivotal single-arm observational study, both in primary, secondary, and MAC cohorts of patients. Another device is the Tendine device, which is a transapical device, which is unique in that there's a tether to an apical pad and multiple different valve designs that are available with this device. They're involved also in pivotal clinical trials. Over 600 patients have been treated worldwide with the Tendine device, and they're randomizing this in certain patients against MitraClip with 2 parallel registries in high risk and MAC patients. So for mitral therapies, I would say the transcatheter will significantly impact the future of mitral therapy, but without question, both surgery and medical therapies will have important roles. For the mitral valve, we need more of a toolbox approach. Surgical repair for primary MR and guideline-directed medical therapy, which is evolving for secondary MR, are still major contributors. The significant growth in edge-to-edge repair, I think, is important, but we need additional clinical trial evidence. And as I've mentioned, TMVR, and especially with transseptal access, will play an important role in multiple anatomic scenarios, including MAC. So the vision of this is a multi-device lesion-specific approach for initial therapy choice, followed by combination therapies for recurrence or device failures. And finally, tricuspid disease. There are many challenges when approaching the tricuspid valve. Little is known about this previously forgotten valve. The imaging is difficult for accurate diagnosis and therapy. Identifying irreversible RV dysfunction is problematic. The timing of transcatheter treatment remains controversial, and the safety and clinical value of transcatheter therapy is only in early development stages. The etiology of tricuspid regurgitation is largely functional. There's a smaller number of patients that have organic disease, and some where the TR is largely related to pacemaker lead interference. There are many devices that fall into three general categories: annuloplasty, direct or indirect, leaflet-based devices, and then valve transplants, either heterotopic or orthotopic, that are shown on this slide. And the goal in the future will be how to choose which device in which clinical scenario and in which anatomy. And Sushil is among the world's leaders in being able to evolve tricuspid therapies and help us to understand what these choices will be. There's very little clinical evidence. There is a large international registry involving 535 patients called the TriValve Registry, and patients with TR who've been treated with new transcatheter therapies, mainly MitraClip, which has been compared to medical therapy in a propensity match series. And that's shown here, was published a few years ago, and showing some promising evidence from the standpoint of improved survival and improved survival free from heart failure hospitalization. So maybe this will be an important therapy in the future. We are excited about the tricuspid valve. We actually believe the transcatheter tricuspid therapy will dominate the treatment of tricuspid regurgitation. We predict that there'll be explosive growth as sole therapy and combined with mitral therapy, and also even at earlier stages in disease. The technology refinements are expected for all device categories, with important roles for each category: replacement and repair. What's needed? We need a better understanding of preferred device use for specific anatomies and clinical scenarios. We need to improve imaging for diagnosis and therapy. We need to understand some of the major risk factors and improve clinical management strategies. We are fortunate that there are going to be some facilitated regulatory approval pathways and some creative clinical trials, with 3 large randomized trials already ongoing. So we are moving very quickly in the transcatheter tricuspid space. So to conclude, what is the future of valvular heart disease therapy? I've just given you a snapshot of where we are and perhaps where we're going in the 3 major valves that we are treating. I would simply say that the future is, very simple. There will be transcatheter dominance in the management of severe valvular heart disease, with expected creative evolutionary changes. Thank you very much for your attention.
Thank you, sir, for highlighting some of the newer aspects and also bringing up new concept of upstream treatment for aortic stenosis. Always very intrigued by new terminology, new therapy modalities which you bring up. You brought CHIP before to this world, then now upstream aortic stenosis and many other things. I think we have Dr. Ajit and Dr. A.B. Mehta, sir, a few comments, and then we'll go to Sushil's lecture.
Thank you, Dr. Young, for an absolutely fantastic review of what's the future and what's the crystal ball we're gazing at. I can't disagree with you on any of the points, and I think that this is where we are all going to go. It's all going to be transcatheter for the aortic. We need some technologies for the mitral, but I think for the tricuspid, more or less, I think the technique will evolve like the mitral clip. and give outstanding results. So thank you very much for starting out this session with a clear vision of the future.
In India, I think, sir, mitral valve and tricuspid valve therapies would be more applicable also because our patients are a little younger and we do see a lot more of this disease, unlike West where you have more of degenerative aortic valve disease in elderly. I think we look forward to such the new technologies coming up. I think Dr. A.V. Mehta, sir, your comments?
I totally agree with you. And Martin was a fantastic talk. I think, as Albert Einstein always said, that today's imaginations is tomorrow's reality. And Martin has simply confirmed what Albert Einstein said in the past. The important point is that the time should be that we are able to apply these therapies to our rheumatic patients also. In time to come, I think we should be able to do that also. And I think I agree totally with you as well as Dr. Ajit Mullasari that this was an eye-opener. What Martin said is every word. I think I have listened very carefully. It was like a poem. Thank you, Martin.